Okay, we have two speakers today, like I mentioned. One of our speakers is Dr. Osi Kufor, who is a public health professional, and he has a passion to improve access to quality healthcare for the underserved and less privileged in society. He has 10 years of experience designing and implementing public health programs spanning a variety of key areas: HIV/AIDS, tuberculosis, maternal and child health, integrated services, including family planning. He currently works as a technical officer, cardiovascular health for Resolve to Save Lives in the Nigeria country office. And he supports the government and relevant stakeholders to reduce the burden of NCDs, focusing on cardiovascular diseases by improving population blood pressure control. This has been done through integrating and strengthening hypertension prevention, care, and treatment services at the primary healthcare level. So he's very vast in this particular area that we're discussing. He works with stakeholders to foster an enabling environment for nationwide scale-up of hypertension treatment services through decentralization of treatment, enabling tax sharing and team-based care, ensuring access to affordable, quality-assured medicines, availability of basic medical technologies, and development of policies that facilitate sustainability. So he has done this for a number of years. He has coordinated the pilot project seeking to integrate hypertension diagnosis, care, and treatment in HIV service delivery systems. Please, a round of applause for Dr. Kufor Osi. Please clap before he changes his mind about giving us the lecture today. So I want to see all the hands clapping in the chat and on your own page. Thank you so much. I see the hands. Thank you. And then our second other speaker today is thank you, Elizabeth. Our other speaker today is Dr. Jiancheng Ye. I had to practice this name. Can we go to the next slide, please? I had to practice this name. I think he will tell me if I made it, if I finally got it. He is a researcher from Northwestern University, Finsburg School of Medicine, and his research interests lie broadly at the intersection of data science, health informatics, and implementation science. He has been working on the hypertension treatment in Nigeria program with a focus on retention in care. So what we're about to discuss today, he has done some extensive work with the hypertension treatment in Nigeria program, and he'll be sharing with us today over the next 10 minutes some of the insights that he's seen from the program when it comes to retention. So what are the barriers to linkage and retention when it comes to hypertension care? What are the barriers that have been noticed and have been observed? And then we would have immediately after he's done, we would have Dr. Osi tell us, even diving deeper into these barriers, but also speaking on the strategies to be able to surmount these barriers. So a round of applause for Dr. Ye, please. I want to see the hands in the chat, please. I want to see those clapping. Thank you very much. So we would hand over very quickly to Dr. Ye. Please go ahead, sir.
Can you hear me okay?
Yes, we can.
Thank you very much for your kind introduction. Hi, everyone. My name is Jiancheng Ye from Northwestern University in the United States. Could you please go to the next slide? So for the hypertension treatment in Nigeria program, which was funded by NHLBI in the United States, which is a large clinical trial to implement hypertension management intervention in Nigeria. We conduct 2 workshops last year to have stakeholders, for example, clinicians, pharmacists, nurses, patients as well as community healthcare workers. We want to hear those different stakeholders' perspectives towards retention in hypertension care. We map them into this CIFR framework, which has 5 different domains, including innovation, inner setting, outer setting, characteristics of individuals, and process. So going to the innovation, there are 3 barriers. For example, some people are concerned about the effectiveness and side effects of blood pressure lowering drugs. So they do not have a good retention into the primary care center. Some people already have a good medication adherence. So they just prescribe drug regularly, then they not have a good follow-up with the primary care center. And in Nigeria, they do not have a very sophisticated electronic record system to track patients' visit time, which made it challenging for the clinicians as well as the research team to track patients' visit time. And in terms of the inner setting, some stakeholders mentioned that they are experiencing the low quality or lack of counseling in the primary care center. And clinicians are very busy. Some centers do not provide enough seats for patients. So patients were not so satisfied with the health service in the clinics. And they have to wait for a long time to receive the care from the clinicians. And some clinics, they are lacking of pharmacists, permanent staff, and they are busy to take care of all the patients. In terms of the outer setting, some patients, they are expressing concern about the geographic distance. They are living very far away from the community healthcare center or primary care clinics. So they are not willing to have a regular follow-up with the clinicians and to receive hypertension care. And in Nigeria, the insurance coverage is relatively low to receive appropriate hypertension medications, so which also influencing the retention. And in terms of the characteristics of individuals, some patients do not have enough income. They are very busy, so they may not have a good retention. Some patients have severe health condition which prevent them going to the clinics regularly. And some patients, they do not have a good awareness of the importance of retention. They don't think regular follow-up will improve their blood pressure control. And language barrier is another challenge because some patients do not speak English. And most clinicians, they speak English in Nigeria. They do not have a good communication. And patient migration to other places, which also be barriers. They have to build their new relationship with the healthcare providers in the new places, and which also prevent them to receiving appropriate care in time. And going to the process, the transportation in Nigeria is also another barriers. The time schedule of the train to the clinics is sometimes tricky for patients to have regular follow-up with the clinics. And sometimes people are very busy with the running and the farm season. They have to do the farm work, so they do not have time going to the clinics during that season. The cost of drugs also giving people burden to have regular follow-up with the clinicians and to buy the medications. And from the macro level, the drug supply chain in this country also needs some improvement to enable patients to have a better supply of the medications. So here we highlight 5 different barriers which Dr. Osi will provide more details and what kind of strategies he would think be effective to address these barriers and improve retention. Thank you very much.
Thank you so much, Dr. Ye. And like I mentioned, he has done extensive research on this and has clearly and carefully articulated some of the barriers. So we're just going to leave this on the screen for another 30 seconds for us to just see some of the barriers to retention, which he has explained in detail. Dr. Osi is going to go deeper into some of these barriers and then speak to us on some of the strategies to be able to overcome these barriers. So very quickly, we would hand over to Dr. Osi. If you can hear us, please go ahead.
So yes, thank you so much, Dr. Ye. I think Dr. Ye had already laid this very solid foundation for my presentation, so I'll just build on that, and then I'll try to be very fast so we can manage the time. So thank you, Adora and team. So next slide, please. So yes, I'll be talking to us on some practical strategies that we can use really to improve linkage to care and also retention in care for hypertension care and treatment services. So I'm going to start off by telling us a story of two conditions. I'm sure most of us, we know HIV, AIDS, and hypertension. So let me tell you a story of these two conditions. So one of the things you must bear in mind is that both HIV and hypertension are both chronic. They are both chronic conditions requiring lifelong therapy. So for conditions like HIV and hypertension, for you to be able to manage them effectively, you require robust systems for retention and continuity in care. It's a very, very important prerequisite if you are to set up effective treatment programs for HIV and hypertension care and treatment. Like I've said, both of them are chronic conditions which would require lifelong therapy. So if you look at the lower part of your screen, that's like a cascade, a treatment cascade that can serve for both HIV and hypertension. So the first step is really around health education. And then after health education, you screen. But for screening, that means you measure the blood pressure for hypertension, where you conduct the testing for HIV. Of course, you make a diagnosis, and then you link patients to treatment, and then eventually, of course, the end goal is really to have the person's blood pressure under control and also to have the person to be virally suppressed. So if you look at the connection between diagnosis and treatment, that's where really linkage to care happens. And we'll be defining these terms, linkage to care, later. And then also, of course, between treatment, the point after you started the person on treatment, and when the person eventually achieves blood pressure control, or when the person achieves viral suppression, that's when we talk about retention in care. Next slide. So this is it, HIV and hypertension, a tale of two conditions, similar conditions, a lot of commonalities between them, but different pictures. So the left, you can see, shows the global cascade for HIV, and on the right, you can also see the global hypertension cascade. So you can see there's a glaring contrast between both cascades. So while you can see that there are significant drop-offs between each step of the cascade for hypertension, in HIV, you don't witness that much significant drop-offs. So you can see around 33 million persons have been diagnosed to be HIV positive. Out of these 33 million, 29.8 million are on treatment. And out of the 29.8 million that are on treatment, 27.7 million have achieved viral suppression, meaning that they have been retained in care, they are coming to the hospital or to the facilities, and they are receiving their antiretroviral therapy. By the time you come to the hypertension cascade, out of 691 million persons that have been diagnosed, only 538 million are on treatment. So you see there's a drop-off of over 100 million persons. And then again, only 269 million have been controlled. And of course, for your blood pressure to be controlled, it means you need to be retained in care. You need to be adherent to your medications. You need to be adherent to your clinic visits and to your laboratory appointments. So again, I just wanted to point out that one of the major differences between this, why we're having this contrast in these pictures, is really around the excellent linkage and retention in care for HIV and the suboptimal linkage and retention in care for hypertension. Next slide. So we are going to be looking at what is linkage to care and what is retention in care. So again, linkage to care is a one-time event. It's an activity that happens, it's a one-off activity. So linkage to care is defined as patient entry into hypertension care and treatment after diagnosis Or you might want to say it refers to efforts that are being made by healthcare workers to link a newly diagnosed hypertension patient to medical care for hypertension. Now, of course, linkage to care simply means after you've made the diagnosis of hypertension in a patient, you then start the patient on treatment. So that's just the meaning of linkage to care. And so, of course, it usually refers to the time between you make the diagnosis and when the person starts the hypertension treatment. So, of course, if you look at the patient's treatment card, you basically see date of diagnosis, and you also see date of treatment, or what we call treatment start date. So that time is really what we refer to as linkage to care. The global recommendation from the World Health Organization is that every individual that is diagnosed be linked to hypertension care and treatment within 1 month of diagnosis. That is the global recommendation by the World Health Organization. But what we see practically on the field, even in most health treatment programs, is that we see what we call same-day initiation. So what I mean by same-day initiation is on the day you make the diagnosis, it's also the day, if proper counseling has been provided, you can link the patient to treatment. So while linkage to care is a one-off event, retention is an ongoing activity. Retention in care is an ongoing activity. It refers to ongoing participation in hypertension care and treatment by patients that have been diagnosed and linked to care. So here, patients are expected to engage or receive medical care regularly from a facility. So remember the key difference. Linkage to care is a one-off activity. After diagnosis, you start the patient on treatment. While retention in care is ongoing, it means the patient needs to come back to the facility frequently to receive his or her care. And of course, you know that care goes beyond just taking medications, also all that examination, medical counseling, laboratory tests. So there are several ways to define retention in care. So the global standard, again, by the World Health Organization. So for retention in care, there are probably 2 indicators. One is referred to as missed visits, and the other one is referred to as loss to follow-up. So for missed visits, it simply means a patient that has not visited the hospital or the facility to receive his or her care for the past 3 months. So if for 3 months a patient had not visited to receive his or her care, then you have a problem. That's what you refer to as missed visits. And then going beyond missed visits, you can progress further up the ladder, and then when the patient now becomes to as loss to follow-up. So the WHO defines loss to follow-up as a patient that has not visited a facility in 12 months, in a whole year, to receive care. So it means that, oh, you have diagnosed this patient, you have started this patient on treatment, but in 12 months following that treatment commencement, that patient has not visited the facility to receive his or her care. Next slide. So again, Dr. Ye has spent so much time on this, so I'll just quickly run through this. What are some of the reasons for poor linkage and retention? Of course, I try to group them into health facility providers and patients, but Dr. Ye has spent a lot of time on this, but I'll just run through. For health facility, medication stockouts. Of course, Dr. Yi mentioned this geographic coverage when there's very long distance from the patient's residence to facilities, when the cost of treatment is very high, low insurance coverage, like Dr. Yi had mentioned, when patients go to the facility in the morning and they don't leave until evening, long waiting time, irregular availability of healthcare workers, and of course, poor documentation. So we're going to talk about this in the later parts. And for the providers themselves, when there's lack of trust from the patient side, lack of empathy, as healthcare workers, we must be able to display empathy when we attend to our patients. One thing we must bear in mind that empathy is different from sympathy. So with empathy, you are not expressing pity, but what you are trying to do is also provide solutions to the person for his or her challenge. And then, of course, poor communication skills. As healthcare workers, we must be able to communicate clearly. We must be able to ensure that we pass the message the right way, the right manner, that the patient will understand. And then what are some of the facilities for patients, some of the factors for patients? Lack of patient education. When the patient is very elderly and requires support, when patients are severely ill, bedridden, issues of mental health, those patients will require assistance. Of course, forgetfulness. A lot of patients forget to take their medications or their hospital appointments, asymptomatic conditions. So we know that this is a major issue, especially here in Africa. Most patients will tell you that, you say I have hypertension, you say that my BP is high, but I don't have headache, I'm not feeling sick, I'm not having any weight loss. Why are you saying that I should come and be taking drugs, I should be swallowing drugs, I should come into the hospital every time when I'm not sick? So asymptomatic condition is a whole lot of issues. Of course, lack of social support and self-efficacy. The patient must really be motivated for the patient to be able to be adherent to his or her medications, his clinic appointments, and also his laboratory appointments. Next slide, please. So what are some of these strategies we can use to reduce loss to follow-up, which we are going to talk about in depth in the next following slides? So the first one is really around health education and adherence counseling. I think we're going to talk more around adherence. The next is really on the follow-up and the tracking system. This is very important. The other ones are decentralization and patient-centered services. And then finally, we'll also talk about the availability of health services. Next slide. So again, very importantly, health education and adherence counseling. This is the first step in the treatment cascade. And you agree with me that the first step in any process is very important, because if the first step is faulty, it means that the rest of the other steps in the cascade or in any other process would be fraught with challenges. So health education and counseling before the commencement of medication is perhaps the most important step of the cascade. As healthcare workers, we must understand that counseling is a form of communication, right? So one of the things that we have learned from experience in programming is that generally people don't take advice. So healthcare workers are not supposed to advise, but rather healthcare workers are supposed to counsel. And how do you counsel? In counseling, you help the patient or the client to identify the problem. And after helping the patient or client to identify the problem, you also provide solutions to the client to resolve them. You work with the clients to make what we call an informed choice or an informed decision to choose from the plethora or the possible list of solutions you have given to the client to choose the solution that is best and most convenient for the client. So this is what counseling entails, or what we refer to as counseling. So healthcare workers should not be giving advice, but rather you help the client and patient identify what the problem is, provide a possible list of solutions, work with the client to identify which solution is the best and most convenient for the client. One other thing we must also understand, like I've said, counseling is communication. And for communication, it's both verbal and non-verbal. So when we are communicating with the client, we must be seen to be listening to the client. The client needs to know that we're listening to him or her. Apart from that, we must be non-judgmental. And remember that client communication is both verbal and non-verbal. So the client is watching out for your body language. The client is watching out for the tone of your voice, your body dispositions. And again, it's also important that as you're communicating to the client, at regular intervals, you pause, check and ask the client's question to ensure that the client is understanding, that there's a shared understanding of what you intend or the message you intend to pass to the client. That way you can pause and say, Madam, Oga, what have we been discussing since? That way you allow the client to paraphrase and use our own words, and you can be sure that the client has the proper understanding of the message you're trying to pass. Next slide. So what is adherence? Because every time you hear adherence. So adherence refers to taking the right medications at the right dose, at the right time, and in the right way, as agreed between the patient and the healthcare worker. So you must look at the keywords: right medications, right dose, right time, right way. Very important, as agreed between the patient and the healthcare worker, not as the healthcare worker told the patient. No, the patient and the healthcare worker would agree. So adherence goes beyond just medications. It also covers clinic and laboratory appointments. So when you say the patient adherent to medications, yes. Is the patient adherent to his or her clinic and laboratory appointments? It's very important because it just goes beyond medications. So there's a difference between saying, compliance and adherence. Of course, in the past, the term used to be patients are not compliant to medications. That was the practice in the past. But now, what we have now realized that the best way to go is adherence. So in adherence, the patient plays an active role, while in compliance, it is the healthcare worker that makes all the decisions. So again, the main difference, like I've said, is when you sit down with the patient and you're counseling and communicating with the patient, you and the patient will agree on what works best with the patient. It's not the healthcare worker to impose decisions and say, Oga, you must take this medication by 9 p.m. every day, or you must take this medication by 9 a.m. every day, or you have to visit the facility by 12 noon on so date. No. Because if you say so, you don't know if the patient works at night and the patient might not be able to take his or her medication. So you need to sit down with the patient, find out and inquire from the patient when is the best time, possible time for the patient to take his or her medications. And also, you also plan a visit, appointment, clinic appointment, and laboratory appointment when it is most convenient for the patient and also for you, the healthcare worker. So that is the difference between adherence and compliance. Next slide. So success of adherence is dependent on the following. One, the quality of information and education that the healthcare worker provides before they start medications. Like I've said, at time intervals, you need to assess the patient's understanding of the information you're providing. Again, another point I need to stress here is that commencement of medication or treatment for hypertension is voluntary. I know sometimes we want to say, oh, let our data not look good before they will say we have identified 100 cases and we've started only 10 on treatment. We must not impose commencement of treatment on patients. It's really voluntary. And for you to be able to get patient to that state of motivation, you can do that by providing high quality health education and adherence. That way, the patient will see why it is important for him or her to commence medications. Again, before your patient even commences medications, you must be able to assess and identify what would most likely be the obstacles against hypertension treatment. So when you have a list of the most likely obstacles, then you can also propose solutions and work with the patient to implement the most convenient solutions for him or her. Next slide. So what are those points, or what are those key points that you need to communicate to the patient during health education and adherence counseling? The first one is that you need to emphasize the asymptomatic nature of hypertension. So we know that for most cases of hypertension, it is without signs and symptoms. So the patient will be apparently healthy. But we know that if left untreated, hypertension can progress to fatal endpoints. And if not fatal endpoints, endpoints that have severe morbidity, that of course we know all those comes with associated costs to the patient. So if hypertension is left untreated, it can progress to stroke, kidney failure, heart disease, heart attack. Again, you must explain to the patient what you mean by asymptomatic nature. So the patient can be apparently healthy, but meanwhile, the patient has hypertension, and we know hypertension is a silent killer. The other thing you need to tell the patient is that medicines, the antihypertensive medicines that are available have the ability to control the blood pressure and prevent progression of hypertension to these endpoints that we want to avert, these endpoints such as stroke, kidney failure, and heart disease. You also need to explain to the patient that treatment is lifelong. This is very important. Once a patient starts treatment for hypertension, it's expected that the patient will continue to take the medications for a long time in order for the blood pressure to remain under control. So explain to the patient that there's a difference between antihypertensive medicines and then medicines for quick relief, such as wheezing, malaria, headache, and all of that. There's a difference. And this is where hypertension is very similar to HIV. Explain the importance of regular treatment and adherence to medications. You need to tell the patients how to take the medications, how to recognize side effects. If there are common side effects associated with that particular antihypertensive medication, you need to explain them to the patient and also tell the patient what to do if those side effects occur. Finally, you and the patient need to agree on a plan on how to take the medication. It is very important, like I said, don't impose your decision on the patient. Work with the patient to identify a suitable plan that the patient can adhere to or the patient can keep to. Then finally, the last but not the least, remember that at each point in time, you need to be able to assess the patient's understanding of all the information you are providing. So because you are going to be loading the patient with a barrage of information, so at some intervals, you need to pause and allow the patient to tell you what he or her understands in the form of communication you guys have been having. So how do you assess adherence? At each visit of the patient to the facility, you need to be able to ask some key questions. Questions such as, what time do they take the medication? Do they take it with food or not? Who gives the medication? What issues they have had with the medications? And what measures do they take to remember the medications? This is very important because by the time you ask these probing questions, you'll be able to identify if the patient has been taking his or her medications as agreed or not. So how do we assess adherence? There are several ways we can assess adherence. One of the ways we can assess adherence is through self-reports from patients. Of course, when patients visit the facility, you can ask the patients if they have been taking their medicines or not, but we know the dangers is that some patients might not be able to tell you the truth. Then the other thing we can do is look at pharmacy refill counts. So we can look at the pharmacy refill patients, and then so for pharmacy refill counts, we're simply looking at when you give the patient a prescription, does the patient go to the pharmacist to pick his or her medicines? So you can also look at that to measure adherence for the patient. The other thing you can do is pill count. So when you give a patient a pack, by the time the patient visits the hospital for resupply, you can count how many tablets are remaining in the pill pack. The other thing you can do is the measurement of drug levels. This is really the gold standard. So for measurement of drug levels, there are some biochemical tests you can measure to identify metabolites of the medicines inside urine. And of course, ambulatory blood pressure, which is really the gold standard. So if a patient has actually been taking the blood, his or her medicines, antihypertensive medicines, it should have an effect on the level of the blood pressure. Other methods that could be used electronic monitoring systems. So we have digital medicines. For electronic monitoring systems, once the patient opens the container of the medicines, it sends an alert. So digital medicines that is all the same. Once the patient takes it, you can get an alert. The other one is the directly observed therapy that we do in TB, where the patient comes to the hospital every day, and you, the healthcare worker, observe the patient taking the medicine directly. Next slide, please. Next slide. So what are some practical tips that we can use to improve adherence, or practical tips that you can tell the patient that the patient can use to remember when to take his or her medicines? One practical strategy is to integrate medication taking with routine activities. So we know that for some of our patients that are Muslims, that have the morning prayers, afternoon prayers, and night prayers, if you discuss with them and they think that it is most convenient for them to take their medicines at night, maybe you can ask them to start taking the medicines when is the time for the last prayer or is the time for the first prayer of the day. Also, some of our parents, we know our patients, they have popular or TV radio shows. Some of them watch the news at 6 p.m., 8 p.m., 12 noon, as the case may be. So by the time you discuss with them, you can then ask them to integrate their medication taking with this favorite or with their favorite activities such as prayer time, meal time, and even TV and radio shows. Other things you can do is also link medication taking to maybe sunrise and sunset of the day. Another thing is we know we're in the digital era, so you can work with them to set up a time reminder. So if they say they want to take their medicines every 10 a.m., they can set up an alarm or a reminder on their phone, their watch, their clock by 9:50 a.m. So once it's 9:50, they get a reminder to say they should take their medicines by 10 a.m. So you can work with them on that. The last but not the least is the use of treatment supporters. So patients usually have close family relatives or friends that they trust, and the treatment supporters can be very important because they can help to remind the patients to take their medicines. And if patients are ill and cannot come to the hospital themselves, these treatment supporters can also bring the patients down to the hospital and can serve like an additional layer for the healthcare worker to reach out to when the healthcare worker cannot reach the patient directly. Next slide, please. So away from health education and adherence counseling, which is very important, like I said, is the first step. The other thing we need to do is follow up and tracking systems. So once a patient has been diagnosed and linked to care, it is important that you have a follow-up system or a tracking system that would promptly identify patients that have missed visits. That's patients that were supposed to visit that have not visited the facility. You should have a functional system in place. For facilities that have electronic medical records, the electronic medical records can automatically generate this list. So you can configure it to generate it at a routine frequency. Do you want it to generate it every week? It identifies all the patients that were supposed to visit that week that had not visited, or every month. So that can be done. And once you have that list, you as the healthcare worker, you need to follow up with the patient. So how do you do that? It is important that at the onset, when you're registering the patient, you have a complete documentation of the patient details, from the name, the descriptive address, the phone number, and the contact details for any relative or treatment supporter. So what we mean by descriptive address is you give one. So if anybody has to go on a home visit, that person can use that common or popular landmark. Again, when you're recording the name of the patient, it is very, very important that you record the name that the patient is known in the area where the patient stays. So a lot of patients can be, you have names like my name, Kufor Osi, but when you come to my compound, what they know me is Papa Bomboy. So it would be good to have those nicknames. So when you come to the compound, you'll be looking for Dr. Kufor Osi, but no, they will tell you they don't need Dr. Kufor Osi, but you say, oh, but by the time you say you are looking for Papa Bomboy, they'll quickly take you to Papa Bomboy's house. And it's also very important that you have functional phone numbers. So even as healthcare workers, as you're registering a patient, you should endeavor to try and check if the phone number is active. So once you have that list of defaulters that's been generated, you can use several strategies to actually return them back to care. One of them is by sending them text messages. Another method is by giving them phone calls. By the time you send a text message, you give a phone call. Of course, the other thing you can do is embark on home visits. I know at the primary healthcare level, we have community health extension workers whose role and responsibility is really to program within the community. So you can hand over such lists to them, and then they will be able to go and visit these patients and find out what the issues are and be able to return them back to care to the facility. Next slide. So decentralization and patient-centered care, some of these strategies have been developed to respond to some of the reasons for loss to follow-up. Like Dr. Yi mentioned, one of the major reasons for loss to follow-up is geographic or poor retention is geographic coverage. I talked about it when I said long distance to facilities. So for some patients, because the facilities are very far away from their homes, the cost of transporting themselves down to the facility is very high. They are discouraged from going down to the facilities to receive care. So this is why we must be able to decentralize. We need to be able to decentralize hypertension care and treatment from the primary healthcare facility to health posts, or even to community pharmacies that are nearby or where the patients can access them easily. So one of the things we also have is what we call differentiated service delivery approach. So differentiated service delivery approach simply means that different categories of patients will get different types of care. So if I'm a hypertensive patient that's on treatment in your hospital, I've been on treatment for 2 years, my blood pressure is controlled. The way you manage me is not the way you manage somebody that was just diagnosed yesterday and you're just linking to care. For patients that have their blood pressure controlled, they have been on treatment for 2 years, those patients would have been highly educated and sensitized on how to manage hypertension and all of that. So such patients can receive multiple months supply of medications. That's what we call multi-month dispensing. So for such patients, instead of giving them 1 month supply of medications and giving them 1 month appointments, you can give such patients 3 months supply of medications and give them 3 months appointments. So that's like an incentive or a reward for good behavior, because the patient has been coming, the patient's blood pressure is now controlled, the patient has not missed any laboratory appointment, any clinic appointment. So we need to consider what we call differentiated service delivery approach. And one of the methods under that differentiated service delivery approach is multi-month dispensing, where you give multiple months supply of medications at a point in time. So for patients that have their blood pressure controlled, they can have up to 3 months supply. They can even have up to 6 months supply, as the case may be. But of course, remember that when you're doing multi-month supply, multi-month dispensing, you have to create points or intervals where the patient has to come to the hospital for proper clinical examination and all of that. So for differentiated service delivery approach, several approaches exist. You can have the ones that will happen in the facility, the one you can implement in the community. You also have support groups, a group of patients that have their blood pressure control, group of patients being treated for hypertension, where they come together to support each other. And you can also deliver the medicines into the community. In this era of the digital age, we must also consider telemedicine. So during the COVID era, one of the things that was implemented was telemedicine, where medicines were delivered from the facility to the doorstep of the patients, and then the patients would now continue communication with the healthcare worker over an app, over a telemedicine app like the mDoc app. So that way it reduces the frequency or the need for the patient to visit the facility. So the healthcare worker would only require the patient to visit the facility when there is a need to do so. And of course, other things about patient self-care, such as home blood pressure monitoring and all of that, can be deployed under decentralization and patient-centered care. So the final point is really around availability of health services, providers, and medicines. So one thing I want to say that even if you have all of these things in place, the decentralization, you have a functional tracking system, good, robust health education, adherence counseling measures, the truth is, if you don't have healthcare workers at the facilities, or you don't have the antihypertensive medicines at the facilities, we will still not be able to make any progress. This is what we refer to as missed opportunities. So a patient comes to a facility and does not meet a healthcare worker on ground to be able that can provide that hypertension care and treatment. Or even when a patient comes to a facility, a healthcare worker attends to the patient and medicines are prescribed. By the time the patient goes to get the medicines from the pharmacy unit of the facility, the patient is told that there is a stock out. You know that when the patient goes back to the community, the story will be that, oh, that primary healthcare center, they are not working. Please don't mind them. Don't go there. They don't have medicines. That kind of situation can make patients lose confidence in the facility. So at every point in time, it is advised that let the healthcare workers be properly equipped, let the facilities be properly equipped with the BP fix, with the antihypertensive medicines, and let the health workers have their capacity built to be able to offer comprehensive hypertension care and treatment. Another thing to consider for the medicines is fix dose combination. So there's what we call pill burden. Pill burden simply means for patients that are, say, for example, patients that are on amlodipine 10 milligram and losartan 100 milligram, you will now give them 2 tablets of amlodipine 5 milligram and 2 tablets of losartan 50 milligrams. So at one point, the patient has to take 4 tablets. Meanwhile, you can have a fixed dose combination of amlodipine 10 milligram and losartan 100 milligram in 1 tablet. So that fixed dose combination is usually preferred by patients and help to improve adherence. And of course, the other thing we must consider is medicines with good clinical safety profile. And next slide. So thank you so much. I think I'll just stop here. These are just some of the practical strategies that we can put in place at our healthcare facilities to be able to improve linkage to care and also improve retention in care. It's important to remember that the goal is not really about diagnosing people and putting them on treatment. The main goal is really about retaining them in care so they are able to achieve their blood pressure control. Thank you.
Thank you so much, Dr. Osi. Thank you. You really tried it using the time. Thank you so much for that. I think we have 2 case presentations, but I think we can take 1 or 2 questions before we quickly go to the case presentations and get the recommendations from our speakers. So the first question is, what is the role of patients' family or support system when it comes to retention in hypertension care? Dr. Osi, I think you can take that one.
Thank you, Adora. Thank you for the question. So I think I talked about treatment supporters. It is very important. The patient's family or patient support system, they have a very important and great role to play, especially when it comes to retention in care for hypertension treatment. Like I mentioned earlier, that a treatment supporter is important. At the point where the patient is being registered, it's very, very important to request for a treatment supporter or find out from the patient who serves as the patient's family or patient support or backbone. So what can they do? One, it can help when they can help the patient, remind the patient to take his or her medicines at the appropriate time. And I also mentioned that when the patient is ill, severely ill, and the patient cannot come down to the hospital, they can come down to the hospital to collect medicines for the patient, or they can even bring the patient down to the facility themselves. Again, we all know that we are humans, and as humans, we all need our support system. So that patient family or the patient supporter or treatment supporter can serve as a source of encouragement to the patient, to let the patient know that, of course, the fact that you've been diagnosed to be hypertensive is not the end of the world. And the fact that hypertension is a disease that it cannot be cured, because you know our people, when you tell them that it is something, they have a condition that cannot be cured, the way they react. So that patient, that family support system or that treatment supporter is very important because he can serve to bridge that gap when the healthcare worker is not there. Encourage the patient, like I said, remind the patient to take the medicines, and when the patient is sick, can even come down to the facility to take the medicines on behalf of the patient or bring the patient down to the facility for the healthcare worker to attend to the patient. So the role of the family support system, or as I refer to it as treatment supporter, cannot be overstated, really. It is very, very important, especially for management of chronic conditions like hypertension. Thank you.
Thank you so much, Dr. Osi. I think we have room for 1 more before we go to the case presentation. The question is, the person says, from your presentation, you said WHO considers 1 year as the timeline that a patient is considered non-adherent. At what point should the healthcare worker be worried within that 12 months or 1 year?
Okay, so yes, thank you. So let me correct, let me correct the notion. So 1 year is not for adherence, right? 1 year is for a patient to be declared as lost to follow-up, right? So if you look at, I said there were 2 aspects of the definition, that if a patient has not visited the facility in 3 months, you refer to that patient as missed visits. But if a patient has not visited in 12 months, you refer to the patient as lost to follow-up. Really, for adherence, once a patient misses a single visit, there is problem already. So that it means the patient is not adherent. So I would take adherence to be that once a patient misses one visit. So the ideal thing is once a patient misses one visit, you start tracking that patient, you start getting worried. The ideal thing is that the patient should not miss a visit. That is the ideal thing. So just to re-clarify, once the patient misses one visit, you should be worried. You should start putting measures in place to reach out to the patient to see how you can return that patient to care. By 3 months, the WHO classifies the person as missed visits. And by 1 year, the WHO classifies the person as lost to follow-up. So I can explain the classification as missed visits and lost to follow-up is really around the operationalization. So what the WHO simply means is that by the time the person has not visited in 1 year, you know that the chances of returning that person to care is going to be very slim. So you might at that point choose not to invest resources in trying to return that person to care. But when the person has just missed for 3 months, yes, you can still invest your resources in phone calls, SMS, home visits to be able to return the person to care. But really, for adherence and for retention, if a person misses a single visit, then that should be an emergency. You should immediately swing into action to return the person to care. Thank you.
Thank you so much.